Everybody in person, and also pleased to welcome our friends joining virtually. Congratulations to everybody on the reunions. And it's nice to be able to gather in person after what we've all been through. It's my pleasure to introduce Dr. Mark Taubman, CEO of the University of Rochester Medical Center. He's also the Dean of the School of Medicine and Dentistry and the Senior Vice President for Health Sciences. And I'd also like to introduce Dr. Jack Rowe, who is the Julius B. Richmond Professor of Health Policy and Aging at Columbia University Mailman School of Public Health. He's also the former Executive Chairman and CEO of Aetna. They will be both talking to you today about the future of healthcare. A quick note, there are question and answer cards for the audience. Should you have a question, you can pass them forward to our staff members in the aisles who will bring them forward to our speakers. And for the virtual attendees, you can submit your questions via chat. Thank you.
Thank you. Well, it's a great pleasure to be here. See classmates and little trip down memory lane. In addition to our alumni, we have a distinguished guest here. The lady in blue is the president of the University of Rochester, Sarah Mangelsdorf. Good morning, Sarah. Thank you for joining us. Mark asked me to review some of the trends in healthcare briefly, and we'll have a chance to chat about them and respond to any comments or questions there might be. So I'm basically just going to flip through a set of ideas and that are changing in healthcare at this point. I don't have a lot of underlying data to support these, so I'll just ask you to accept them on face value at this point in order to get through this quickly. But there are basically about 7 big ideas in healthcare that are changing right now. Embedded in these are important trends such as changes in the workforce, et cetera, that we'll comment on as we go along. The first is national healthcare expenditures. And national healthcare expenditures a decade ago were expected to be well over 20% of GDP at this point. And they haven't really increased very much, despite the fact that we have the Affordable Care Act, that many more people are insured, that increases expenditures. But expenditures really have not risen as fast as they previously were rising. And there are a long list of reasons why that is. But at this point, we're looking at a very modest increase between now and 2030. We're at 17.6% of GDP, and it may go to 19.6%. And you may see headlines that healthcare expenditures are now finally over 20% of GDP soon, and that is because GDP is going to fall. Not because healthcare expenditures are going to rise. We're probably going to have a recession. The increases that we are seeing in healthcare are very much related to volume and not unit price. Healthcare economics is very simple. This is like force equals mass times acceleration. It's a very simple equation. Healthcare expenditures are equal to the unit price of a drug or a visit or an operation times the volume, the number of those. And what has been happening in the United States over the last decade is the volume is increasing, but the unit price is not increasing. Okay? There are certain drugs, biologicals, that have increased in price very significantly, but pharmacy is only 9% of healthcare expenditures, and those biologicals are only a little percent of that 9%. So overall, it's not that important on a national level. And the reason the volume is increasing is because the population is aging, and there is a very straight upward line between advancing age and the number of stuff, number of things, healthcare things that happen to you, whether they're preventive things like colonoscopies or medications or visits or operations. Medicare and Medicaid are growing enrollment, and we are gradually turning into a single payer. the government is the single payer. If you, US healthcare, about 55 or 58% is sponsored by the government, and about 68% of the dollars, because Medicare is the older population and they are more expensive. So people say, well, we need single payer. We're getting to single payer. The US version of single payer is that the government-sponsored programs like Medicare and Medicaid are operated through the commercial insurance companies. So there's managed Medicare, there's managed Medicaid, there's my old company, Aetna, does the federal employee health benefit program, et cetera, et cetera. That's our version of single payer, but we are in fact getting there. Medicare is really big. For John Deacon, there are more people in the US in Medicare, John, than there are Canadians in Canada. Okay, so it is really big and is small compared to Medicaid, which is now 80 million people. Amazing, 80 million people. Commercial insurance is basically flat. It hasn't grown much in the last decade. Commercial insurers are growing because they're using Medicare Advantage, managed Medicaid, et cetera. But the traditional commercial insurance that medical centers rely on, this medical center gets paid 91.5% of cost by Medicare. They underpay a little bit to try to create an incentive for efficiency. Gets paid about 52%, I would guess, of Medicare for Medicaid. So those are both under cost, and probably gets about 200% of Medicare from commercial insurance. Doctors complain that commercial insurance doesn't pay enough, but it's paying twice what anybody else is paying. And so the idea is to have a payer mix, which includes at least 20 or 25% of her commercial insurance beneficiaries will permit a medical center like this to have a black bottom line. Many of them don't. So I work at Columbia University Medical Center. Our hospital doesn't have a good payer mix, but our sister hospital, New York Hospital, has a very good payer mix. And so that's how one strategizes to make the bottom line work out. It used to be that there was a lot of cost shifting. And when Medicare reduced its payments, which it has progressively done, doctors and hospitals would try to charge commercial insurance more to make up for this. In order to get away from that, what commercial insurance has done is they have pegged their payments to a percent of Medicare. So, okay, we'll pay you 130%, or in physicians, actually about 112% of Medicare. But when Medicare goes down, we're paying now 112% of a lower number. So it's going down. So rather than having this reciprocity where commercial insurance goes up to compensate for Medicare reductions, the market has changed. And healthcare inflation is much less than the general economy. So the general economy, this is a GDP inflation, is in green here, and here's healthcare inflation, which is in blue. And what you see is the inflation that is ravaging our economy has not yet happened in healthcare. This is very important. And the reason it has not happened is not that Mark's costs haven't gone up, they have. His salary costs have gone up. But this is expenditures, this was paid by the insurers. And those contracts are pretty much negotiated in March and April for the next year that begin in January and run for 12 months. So we are still in contracts that were in fact negotiated before inflation started. And this, since this is almost 20% of GDP, next year, when everybody says, well, maybe inflation will go down, inflation is going to go up because that 20% piece, which has been stagnant, is then going to have the inflationary effect, and it's going to give a boost to inflation. And this is something economists are very aware. Now, the Affordable Care Act, notwithstanding the efforts of one political party at least, is alive and well and has very strong enrollment. There was a period of time where people thought it was dead. It didn't have a pulse. It was people were going to drop out of it because insurance companies were dropping out of it because the money wasn't there for them. Healthy young people, the Republicans passed a bill getting rid of the individual mandate. They thought healthy young people will no longer sign up because they don't have to. They're not going to get fined if they don't sign up. They don't think they need insurance. That leaves a smaller pool of sicker people, and that increases the premium, and you get into what's called a death spiral. That didn't happen. People love the Affordable Care Act. There are 14 million people now who have signed up for the Affordable Care Act, 2.5 million extra in the last year. When Biden came in, he opened up the enrollment, he increased the subsidies, and he rehired all these navigators to help people figure out the system, which is very complex. And that government has stopped doing that for a year or two. So it's alive and well. Payment reform, which is the idea of let's pay you not just necessarily on the volume of things you do, but on the quality or on the importance of the things you do, particularly in Medicare, has basically gone sideways. Value-based healthcare, affordable, accountable care organizations have basically, I think, been relatively unsuccessful. Medicare makes a big deal out of the fact that there was how many hundreds of millions of dollars was saved, but actually it accounts for less than 1% of Medicare expenses. And people who run medical centers will tell you, I talked to the president of the Mass General Hospital, and he told me, he says, well, you know, 50% of our contracts are risk-based, value-based. I said, really? And I said, but it's not 50% of the dollars, right? Because the contracts pay you fee for service for 98% of the money. And then it's plus or minus 2% based on the value. So you can make 2% extra or lose 2%. So it's 2% of 50% or 1% of the revenues at Mass General Hospital are at risk. After 10 years of doing this, we're up to 1%. So this so far has been a huge disappointment. Probably one of the most significant things has been the emergence of very large physician groups. So it used to be the big medical centers would have healthcare systems, and they would buy a bunch of hospitals, and they would maybe merge with insurance companies, and those were the big players in the healthcare system. Now, over the last 2 or 3 years, it's been very large physician groups who are directly contracting with Medicare or with insurance companies, not dealing with the hospital at all. Hospitals are much less efficient than physician groups. The ACOs run by hospitals don't perform nearly as well as the ACOs run by physician groups. Physician groups have some legal and financial benefits I won't get into, but there are restrictions on hospitals that the physician groups don't have. This has led to an influx of private equity money that is buying up very large physician groups. And Oak Street is one company that does this, Agilon, another company that does this. One of the abuses that has come out of that was surprise billing. Large groups of anesthesiologists, emergency room physicians, et cetera, sending these surprise bills. Surprise bills are not the answer to the healthcare problem in the United States. Okay, this is not a solution for anybody, well, other than the anesthesiologists, maybe in the emergency room doctors. So now laws have been passed against that. There's a huge pushback against that. The biggest entity, biggest corporation that owned these surprise bill groups basically went belly up and was bought by another private equity company, which is now being reinvented into something else. And so the financial losses for private equity and surprise billing have been very substantial. So they're taking their hands off, and I think surprise billing is dead. Not so much because of the law that was passed, but because of the losses of the private equity companies. Now, COVID has had some very significant long-term effects. Probably the most important one for acute care is telemedicine. At Columbia, we did about 25 to 50 televisits a year before COVID, visits a day before COVID. That went to 2,500. And people liked televisits. I mean, you know, who wants to go to a waiting room, right? I mean, would you like to go to a waiting room with 30 or 40 sick people coughing? You don't have to get in the subway or your car. You don't have to worry about parking. You don't have to wander through a medical center for 20 minutes like my wife and I did this morning, trying to find wherever it is you're going. You know, I mean, it's really easy. And it's down now to about 25% of visits nationwide. 90% of televisits are mental health. And that reflects the epidemic we have of anxiety and depression in the community. And, but it seems as if it's not going away. And it's expected to increase by about 27% in the next decade. Another reflection of this has been the emergence of a new kind of health plan. We thought we had seen every imaginable kind of health plan. When I was at Aetna, we invented a new kind of health plan called the high deductible health plan. Right now, 35% of Americans have high deductible, but we were the first ones to do this. We used it for Aetna employees to see if it worked. It worked well. It does save 8 to 10%, but there is a high deductible. The new kind of health plan is virtual first, and that is your first interaction with the healthcare provider has to be a televisit. Your access to real healthcare providers goes through the portal of a televisit. So if you sign up for this plan, you promise to do a televisit first. Now, unless you're having crushing retrosternal chest pain radiating down your left arm, I mean, so you don't sign up for a televisit, you go to the emergency room. But if this is a regular, routine, usual, and customary thing, you do televisit first, and many times that physician can tell you, okay, well, I think you should see a dermatologist. I don't like the look of that thing that you just showed me on your cheek or your hand. Or, you know what, you just need a renewal of your prescription, or we'll change your medicine. I think you look like you had allergic to that medicine, and you don't do a visit. These plans save 10%. 10% is a lot. US healthcare expenditures are $3 trillion. 10% is a lot. So virtual first is something that you may see, and some of your patients may have that. And you have to be able, through your office, to support a televisit, because they have to have a televisit. So that's going to increase some of the hassle in some ways. There's a tremendous surge in home care. You know, who wants to go to a nursing home? Who would like to send their parents to a nursing? In New York State, going to a nursing home was a death sentence during COVID because of some really not particularly sophisticated policies that were developed. And the nursing home industry has to be redesigned. Nursing homes are not designed, financed, operated, built, or staffed to handle an epidemic, a respiratory-borne epidemic. So nursing homes are going to get reinvented. And while that happens, people are going to go to home care. And at the same time, there is a tremendous deficiency in the workforce in home care. The healthcare workforce has been a large part of the Great Resignation. 18% of healthcare workers quit their jobs during COVID. Most of them took another job in healthcare, one that they thought was less stressful. So the actual overall healthcare workforce actually fell only by 2.7%, and almost all of that was in long-term care sector. So people are still working in healthcare, but not so much in long-term care. And the workforce shortfalls there are very, very significant. Technology can enable some of the home care, but what is happening in the absence of adequate numbers of home care staff is that the informal care providers, the spouses, the children, are catching the burden of taking care of older, sick people at home. And they're relying on technology for monitoring, for connecting them with a nurse or a doctor's office, for getting answers to questions. He missed his morning dose. Should he take 2 at noon, or should I just skip it? You know, how do I deal with this? And these people are never trained to take care of an elderly sick person. They've never been trained to cope with somebody who's asking the same question every 10 minutes. There is a huge need and market for home care education, home care support. Mergers and acquisitions are interesting. Interesting to me. What we saw for a long time was horizontal integration. And then we saw more vertical integration. And the two kinds of integration are as follows. A hospital can buy a hospital. A doctor group can buy a doctor group, okay? The other kind is a hospital can buy a doctor group. The federal government is clamping down on hospitals buying hospitals because they increase the market share locally and they're monopolistic. So the federal government is finally getting serious about clamping down on mergers. I merged Mount Sinai with NYU. That was a terrible experience. I actually had a full head of hair when that started at 6'2", but here I am. But anyway, so this idea of like versus like mergers and acquisitions, that we're seeing much less of. So what is happening is that the hospitals and health systems with some capital are buying doctor groups, where they're buying different kinds of facilities where they don't run into the market share problem of you're doing too much of the cardiac surgery in Rochester, New York, if you buy that at the hospital, so we're not going to let you do it. And lastly, finally, John Samet is here. John's a distinguished dean of the School of Public Health. He'll agree with this. Finally, population health is getting into acute care, getting into education and medical schools. My favorite is Wisconsin. The legislature told the dean of the med school, we're going to start a school of public health. And he came back and said, no. He says, don't start a school. I don't want you to build the school of public health so I can build a bridge from the medical school to the school of public health. I'm going to change the name of the School of Medicine to the School of Medicine and Public Health. I'm on the board of the Columbia University School of Physicians and Surgeons. We're having more population health. I'm on the board of Harvard Medical School, more population health than the current. So finally, and I remember, and I think this is worth just an extra 30 seconds, when I used to be the president of Mount Sinai, and the first day in class, I would welcome the new students. And one year, a student says to me, he says, what's the difference between medicine and public health? And I said, well, medicine is the application of the scientific method to improve the well-being of an individual. Public health is the application of a different set of tools to enhance and protect the well-being of a population. Simplistic definition. I said, you are here to learn the former, not the latter. That was the wrong answer. But that's what I believed, and that's what we did. And the pandemic has taught us that that's an inadequate strategy to prepare the healthcare workforce going forward. So we'll stop there. Thank you very much.
So I don't know if people have questions. If you do, we certainly will answer them. But you know, Jackie raised a lot of issues. As you know, before this started, I was also 6'2" and had a lot all my hair. But you know, I think one of the things that you said that really is a challenge is that right now, you know, we are becoming a single payer, and the single payer is actually more at Medicaid rates. So 52% of all of the pediatric patients in New York State are Medicaid. And as you mentioned, you got it right. I don't know how you could get so close. We do lose 48 cents on the dollar in Medicaid, and we lose about 20 in Medicare, and we are totally dependent on commercial insurance, which not only has to support the healthcare system, but the academic mission. And right now, I think one of our big concerns is that we, just to support the research enterprise for research intensive medical centers, it's about 60 cents on the dollar. That means for an institution like ours that has about $250 million of research money, it's about 150 that we support, the majority from the clinical enterprise. So as this develops and we see more and more Medicaid, and we see more and more of this transition to a single payer, what happens to academic medical centers?
Well, I think a couple of things I would say. One is the traditional model has been that the university that has an academic medical center owns the medical school and the hospital. And that the hospital has been the source of the clinical revenues to support the medical school. In most instances, and in this case here, I think that's certainly the case, and certainly that was the case at Mount Sinai. And in many of these instances, the transfers from the hospital to school have been very high. As the hospitals are progressively threatened with narrower margins, universities progressively see that the hospitals are risky businesses. And so there may be some changes in that model, and a number of institutions.
I think there already has. There
already
are only few, most institutions.
Presbyterian
has
Hospital
split off.
has spun off many. So that's one of the issues, which by definition is very threatening to medical schools and leaves you without an important source of support. I think more relationships with the private sector are becoming more and more helpful, but they certainly don't compensate for the losses. I think what we're going to see is academic medical centers becoming more specialized and more focused in their lines of business rather than being all things to all people. And we always felt, I mean, I had lines of business when I was running Mount Sinai that were losing money. And I said, well, why are we doing this? We're going to get rid of obstetrics. And they said, well, you need to teach the medical students obstetrics. I mean, where are you going to do it? You know, well, we'll find someplace else, et cetera. So there are a bunch of challenges. It's not obvious to me how it's going to be, but I do believe that academic medical centers are going to be more specialized. In addition, what's going to happen to hospitals is pretty clear, and that is we think that hospital volume is only going to increase about 2%, 2.5% between now and 2030. But length of stay is going to increase. Hospital days are going to increase by 8%. The people who are going to be in the hospital are going to be more complex, multi-problem, more specialty care is probably going to go up 15%. So this idea of if it's all primary care, hospitals that do that are going to go out of business. What's going to happen is the hospitals that are going to survive are the tertiary care medical centers, because that is the stuff that cannot be done in the outpatient, even if it's in Henrietta.
I mean, well, I think we have seen. I mean, when I got here, which is almost 20 years ago, 80% of orthopedic surgery was done in Strong. Now it's 18%.
Yeah.
So part of it is that we've gotten much more successful in doing procedures outpatient, leaving the inpatient to take the real high complexity cases.
Yeah, and that's
The
and so you
transplants, et
have to,
cetera.
and if that's what's going to happen to hospitals, then you have to design hospitals to support that activity, and that's a different looking hospital than the old ones. You know,
So,
comments or questions from people? We have questions, okay?
so I have one more though,
Sure.
before and then I'll try to. So you talked about the workforce. Well, obviously, right now, we're in an unusual situation when you talk about the cost of healthcare. Right, you know, we've now seen this great resignation, but in particular, in hospital staff, it's 15–20%, particularly in key areas like nursing, techs for the OR, and we are seeing huge increases in costs. And when I see that number that we're under the GDP, I mean, this year alone, we've seen we've gone from, let's say, paying $2 million a month for travelers to $15 million a month. So we're looking at $100 million increase in costs in travelers, $50 million increase in costs based in terms of staff. I suspect that what we're going to see is that our costs have gone up substantially.
Yeah.
And that curve may not be there. We may actually hit the GDP higher.
Yeah.
But it's also putting.
And that's going to be a sticker shock for the economy. I think many people don't realize the scale of these large companies through which the funds flow. But I teach a course in the business school of Columbia, and the first slide I showed to get the business school's attention is I have the revenues for 2019, pre-COVID, of Google and Microsoft and Apple and Amazon and Netflix added together. And then I have on the next line the revenue of CVS, Aetna, United, Anthem, Humana, and Cigna. And the second line is bigger than the first line. Okay. And in 2000, 20 years ago, when I walked into my office as the CEO of Aetna, my budget was $1 billion a week. And that's double now. CVS Aetna, by revenue, is the second largest corporation in the United States. I mean, we are talking huge, huge sums. And when that artificially suppressed inflation because of the timing of the contract hits next year on January 1st, it's going to send a chill through our economy.
Yeah.
Yeah.
But, you know, I think that one of the questions is, how do we get the workforce back? Or are we really going to have to change our whole system? I see you're nodding there as CEO of NYU. we're going to have to change our system. Or do you think that at some point that workforce is going to come back? And either it means changing our system by paying much, much more, which then creates a problem for academic medical centers in how do you support your academic mission?
Yeah,
Or
well,
we have to redesign.
well, first of all, I think it's important to fractionate the workforce. The nurses are going to recover. We are actually probably by 2030, we're going to have 250,000 excess nurses. There are enormous numbers of advanced practice nurses in training, doctors of nursing practice in training. And many of those individuals are going to be able to take over a lot of primary care responsibilities. And so that component of the workforce is going to recover. It's in the pipeline. It's quite clear. The physician part of the workforce is not so much hit by COVID. It was going to be a shortfall, both in primary care and specialists, even going into COVID. But largely, it can be compensated for by advanced practice nurses. The real problem is in the lower levels of the workforce. And most countries that have had this problem have solved it by immigration. And even Japan, which is xenophobic and has been famous for not letting you in the country unless you're Japanese in one way or another, passed a law last year that let 500,000 people come into the country to fill these jobs. And depending on who's in the White House and what's going on in Congress, we might or might not have immigration policies that would facilitate this. But I can tell you, in long-term care, you go to a nursing home, talk to the people there. They're all of whom are angels. They're saints, taking care of this very difficult patient population. They have West Indian accents, right? I mean, this is a good thing. They do a great job. But the harder it is to get into this country, the harder it is for us to fix that problem. But the immigration is the answer. I remember when we had a nursing shortage, Mount Sinai, we were recruiting previously unimagined nurses from the Philippines, and they were terrific. And we didn't need them anymore, so we stopped doing that. And I think we're going to be doing immigration. That's my answer.
And is that your answer to the long-term care question as well?
Well, I think we also need, if you think about long-term care, if you think about a nursing home, population in a nursing home, it's got 4 or 5 different components. It's got a rehab component of patients who are covered by Medicare for 100 days or so, and they're getting rehab post-stroke or post-hip replacement, so hip fracture repair. Those people can get taken care of in whatever empty beds there are in the medical center, in rehab units. There used to be rehab units on the campus of all. Now, we had one in Mount Sinai, very successful. NYU has a very successful one, but both medical centers, most medical centers don't have them. And I think we're going to see those. And that's better because the doctors who took care of the patients acutely can follow them, in the same campus, in the next building. Then there's a subset of people who are getting care at the end of life, and they're in nursing homes, and they can get treated at hospice. They can get treated at hospice at home. There's a company, Aspire, that was purchased by Anthem. There's very effective home care hospice programs. Then there's a subset of people who have dementia, but they're physically fit. Well, now we have memory care centers, which are designed and staffed for people, manage people with dementia only. And so you wind up unpacking the previous nursing home population into kind of purpose-built facilities, which are smaller. The COVID experience with the smaller facilities did better. The best ones were these 18-bed greenhouse units, and the worst ones were 200-bed nursing homes. And so, so I think what's going to happen is we're going to see just a redesign of the institutional long-term care.
But we'll need higher levels of support. I mean, part of the problem for long-term care is they lose $200 a day per bed with current Medicaid rates. So if it's a system like ours where by the way, the first 5 months we had 0 cases of COVID because we immediately started full masking. Before there was vaccine, before there anything, before COVID hit Rochester, our nursing homes went completely masking, completely social
Yeah.
distancing,
Well,
and had a chatbot. But I still think that, so I think you can do it, but I still think that we're going to have to figure out a lot of what we're talking about is that the Medicaid rates
yeah,
are
but-
not sufficient to support your healthcare.
yeah, I agree with that. And I think the other piece that we haven't discussed, but in addition to this redefinition and this disaggregation is long-term care insurance.
Yeah.
I mean, that's how other countries do it. We don't have long-term care insurance. I sold long-term care insurance. I didn't sell a lot of it, maybe 1 or 2 policies. Long-term care insurance has penetrated 1% of the market. And the reason is it's voluntary. So if you're young, you don't think you need it. That's when the premium is low. And if you're old, you can't afford it because that's when the premium is high. So nobody buys. And first week I was at Aetna, the chief actuary came to me. He says, Dr. Rowe, I have a request, professional request in my position as the chief actuary. I said, yes, what do you want, Jim? He says, I want you to stop selling long-term care insurance. I said, why is that? He said, it's not actuarially sound. I have no way to figure out what the premium should be. I don't know what long-term care costs are going to be 30 years from now. So I can't, there's no equation. So I'm an actuary. I can't do this. You're making it up. I said, Jim, the good news is nobody's buying it. So don't worry about it. Yeah. So, in the part of the Affordable Care Act, there was a piece called the Class Act, which was put in by Senator Kennedy, who was ill at the time, and he'd been pushing long-term care insurance forever. So they put it in. He died. The Affordable Care Act got passed. There was a sentence in the Affordable Care Act that said that long-term care insurance, it was a voluntary program. It said if it's not judged to be financially solvent by the chief actuary of HHS, it will be removed. And chief actuary said, are you kidding? Of course it's not financially solvent. And it was removed. And that was the end of long. So what we need is a federal long-term care insurance pool where every employee, like Social Security, Medicare, would be a very small amount, puts in such and such. Then the Medicaid discussion is irrelevant. Then you have basically commercial rates that will pay long-term care. So in addition to changing the anatomy and the function, the physiology of a long-term care system, we need a long-term care insurance financing mechanism. That would be my answer for that.
So there are a couple of questions I think I'll just answer. One was, how does our healthcare costs and outcome compare with the British system, percent GDP and outcome? So I can tell you that in terms of percent GDP, and this is true in general of the 30 economic countries, they're more in the area of 7, 8, 9%. We tend to be double in percent GDP. We tend to be triple in the amount of dollars spent per person. Outcomes, depending on what you measure as outcomes, we are either right in the middle of the pack or on the low end. You look at, now we are much more diverse. There's much greater spread of poverty versus being rich. So it's hard to compare this kind of country with others. But even if you look at things like infant mortality, we're at the bottom of the list. So the answer to that question is we're an outlier.
Well, that's all true. I agree with that. The next slide shows the following. If you take the amount that a country spends on healthcare and you add the amount that it spends on social services, and you have A plus B. If you do that for the US and Western Europe, it winds up about the same. So they spend a lot less on healthcare, but a lot more on social
Right.
services.
Right.
So they wind up spending about the same amount. This depends on how you define it. I certainly agree that our outcomes are lousy.
Our outcomes are not good.
And there are, terrible. And there are, the countries that do the best are, of course, the ones that don't have poverty. They don't have social determinants of health. Switzerland does great. Luxembourg, not so bad. Liechtenstein, excellent. Singapore, terrific, But in the United States, the life expectancy difference between us, okay, in this room, and an uneducated Black male is 13.7 years. 13.7 years. In London, Michael Marmot, now Sir Michael Marmot, a colleague of mine, did a terrific paper where he showed as you go from one high-end subway stop in London in the underground to one really lousy neighborhood, you lose a year of life at every stop. I mean, so it really is a subpopulation that we're talking about, which in the United States is very large. And that's the target.
Right.
Yeah.
And I think that's why more and more we as an institution are focusing on health equities, research, health equity disparities, health disparities. In
And
the
that's
community.
part of the population health theme
And
as
that-
well,
right. That I think that I agree that this whole epidemic has sort of revealed just the huge problem with healthcare disparities and the need to address exactly what you're saying. And, to some extent, because I have 3 questions here on the psychosocial model, that's the biopsychosocial model, that it always focused on the understanding that the way you treat a patient is not just based upon what their disease was, but on the social circumstances. And that really does lead into healthcare disparities. But I see there are a lot of questions on telemedicine and the biopsychosocial model, and do they fit? And I would say the answer is yes, they do. Clearly, there are times where you have to be able to put hands on a patient. And I don't think that in general, what we're talking about is that you never see a patient. But really, the biopsychosocial model most is being able to have the time to interact with the patient. And what you hear from the patients is that when they have telemedicine, they spend more time with their physician than they do in actual visits. They may spend 30 minutes, and it's 30 minutes of questioning and probing, which is exactly what we taught our students to do, as opposed to maybe 30 minutes in which they get seen by a lot of people, they sit in a room, people come in and out. So the feedback we get when we get patient satisfaction studies for our telemedicine, it's very high. And it absolutely goes along, I think, with the biopsychosocial model. The other thing it allows us to do, and Ira will appreciate this because it really was one of his proteges, is to reach patients who don't get reached. So Ray Dorsey, whose focus is on Parkinson's disease, he's developed a telemedicine program to see patients with Parkinson's disease. Turns out in New York, only 40% of people with Parkinson's has ever seen a neurologist. With Dorsey, they now can see a neurologist. It doesn't mean they're going to do it every time, but many of those patients could not come in for visits. They can't drive. It's problematic. It's not safe. Here they get telemedicine. Some of that is that they actually have people who can come and help in the telemedicine do things like check a reflex or something. But because of this, the state bought into this. Now he can do telemedicine for any person in New York State who has Parkinson's. And that's a major improvement in the healthcare. So I think that telemedicine becomes very important, not just in terms of redesigning the healthcare system financially, but it's really, to me, it's an adjunct of the biopsychosocial model. It doesn't mean you can do it all. You got to see the patient at some point. You got to lay hands on. But I think overall, and
leverage technology.
Yeah.
For telling us, a postcard, we're already doing it. We send all our lumbar sections home on the day of surgery, with just the pulse ox. Then an Apple iPhone tells if they're an AFib, what their saturations are. We're doing that with eye exams. We're doing that with all other parts of our whole healthcare system. So leveraging technology in the future will definitely make the patient experience better, avoid parking, traveling, getting lost in the hospital, and provide better care. And the patient satisfaction is higher. We have data on that will be presented.
And so in geriatric medicine, which is my specialty, there's been the concern, you know, that that our patient population is not capable of effectively engaging in telemedicine. Average age, when I was running the geriatrics medicine program at Harvard, the average age of our patients was 89, right? So this was not 65. A 65-year-old woman once came to me and said, "Oh, I just got my Medicare card and I'm a 65-year-old, I should come and see you." And I said, "And, you know, if a 65-year-old woman is in my office, she's talking to me about her mother, you know, this is not what I do, you know." And so our concern was that the percent of the geriatric population which is wired, okay, is too small. But it turns out that there is this sort of dramatic cohort difference, whereas today's elderly are much more wired than the elderly 10 years ago. And tomorrow's elderly are dramatically more wired than today's elderly. And so I think that there's going to be a catch up here, but a familiarity, which is going to facilitate this. Now we have the dementia problem, obviously, but those patients are often not alone. And so that may be a solution.
so we have one more question, but we'll be around to answer the ones that didn't, although the answer to a
We'll
lot
be
of the
here to
ones that
answer
you
the
asked
ones we choose to
were
answer.
not. But most of the answers to the other questions are yes, but what outcomes should be measured under a single payer?
Well, that's a really good question. So what outcomes should be measured? So the usual outcomes that are measured are ones that are easy to measure, right? You know, it's like life expectancy, disability-free life expectancy, you know, healthcare expenditures, you know, things like this. I am very much a favor of functional measures, and that's the geriatrician in me. I remember one time in Boston, my clinic was at the Brigham, and I was over there seeing patients, and I had a patient come in from some other town, Palm Beach or someplace, to see the geriatrician, you know, and he comes in and he's kind of an annoying guy, and he's got a long list of questions I could see, and he's bragging to the nurses how he flew up in his plane and all this. And I'm sitting there, you know, oh Christ, what am I doing? I'd rather be in the lab, you know. And so the guy sits down, and I said, and the fellow is sitting at my side watching this, and I said to him, I said, "Well, Mr. Jones, is there anything that you want to do that you can't do?" He said, "No, I can do everything I want to do." I said, "Okay, we're done here." Said, wait a minute, I came from Palm Beach, I got all these questions. I said, we're into function, Mr. Jones. And you're functioning fine. There are a lot of people out there aren't functioning so well, And then I relented and we went through and I examined them, et cetera. But that was the idea. That was a teaching moment for the fellow, Is there anything you want to do that you can't do? So I think there's not enough emphasis in training and in practice on functional measures, and there's too much on some of the other things that are easier to measure. Thank you all.
Thank you.